Hi, everyone. My name is Jen Slaughter, and I am a pharmacist at SSM Health D Medical Group in Madison, Wisconsin. And I practice in ambulatory care. I work in internal medicine and family medicine. My team does management of complex chronic diseases using collaborative practice agreements. So, today I wanted to talk to everyone about the perioperative management of chronic disease and exception to the rule, which is Roux and wine. I don't have any relevant financial relationships to disclose, and my learning objectives are listed here. So, after completion of this program, pharmacists and pharmacy technician learners will be able to summarize the physiologic changes that occur perioperatively for patients that undergo Roux-en-Y bypass procedures. They're going to be able to describe common barriers to care for patients that undergo these procedures. And we want to be able to identify key considerations and recommendations for management of diabetes and the perioperative state. And finally, we want to be able to identify key considerations and recommendations for management of cardiovascular comorbidities like heart failure, hypertension, and hyperlipidemia, and the perioperative state. So, first, we're going to go through the physiologic changes that occur perioperatively for patients that undergo Roux-en-Y bypass procedures. And I'd like to jump off with who should consider these types of metabolic and bariatric surgeries. I asked for feedback from my student, McKenna Matuli, who is a 2025 Doctor of Pharmacy candidate at the University of Wisconsin, and she said that addition of this slide might be beneficial for student learners. And additionally, I'd like to recommend viewers of the webinar read an excellent article published in the July-August 2024 issue of the Journal of the Pharmacy Society of Wisconsin by Ashley Lorenzen and Cecilia Hickey. This was a great read, and I really encourage everyone to check this article out if you have interest in this area. So, as we hop into our content, as with most of what we see in healthcare, the insurance really dictates coverage. So when we think about who should consider who should consider surgery, the insurance is going to dictate who's going to get it, and it varies. For example, Wisconsin Medicaid covers procedures such as Roux-en-Y, but a word of caution is that the Wisconsin Medicaid criteria may differ from criteria in the 2022 American Society of Metabolic and Bariatric Surgery. It also differs from the International Federation for the Surgery of Obesity and Metabolic Disorders, and it may also differ from the NIH recommendations. So, what they require is going to vary. Some insurers are going to require a referral to weight management. They also may require trial and failure of pharmacologic agents and lifestyle changes. So, having said that, the most widely used criteria is BMI or body mass index. So, for class 1 obesity, which is patients that have a BMI between 30 and 34.9 kilograms per meter squared, this procedure is a recognized disease, or obesity is a clearly recognized disease that leads to or worsens various medical and physiological conditions. It reduces lifespan and diminishes quality of life. Both prospective and extensive retrospective studies suggest that metabolic and bariatric surgery should be an option for patients with class 1 obesity who fail to achieve significant or lasting weight loss or see improvement in their comorbidities through non surgical methods. And early research findings have led international diabetes organizations to issue a joint statement endorsing the consideration of metabolic and bariatric surgeries for patients with a BMI of less than 35 and type 2 diabetes. Metabolic and bariatric surgery should also be considered for patients with class 2 obesity or a BMI of greater than 35 kilograms per meter squared. When we consider the robust scientific evidence on the safety, efficacy, and cost effectiveness of surgery in enhancing survival and quality of life in this patient population, it should be strongly recommended for these individuals, regardless of whether or not they have obvious obesity related comorbidities. Current non-surgical treatment options for patients with a BMI greater than 35 are really ineffective in achieving substantial and sustained weight reduction needed to significantly improve their overall health. And finally, I couldn't really figure out a great place to put this information, so I stuck it here. But for those viewers that aren't working in the ambulatory care setting, or you haven't really been exposed to periop management before, usually when we're thinking about diabetes, our surgeons are going to want an A1C of less than 8% prior to the surgery, or they're going to cancel it. And this is pretty common for most elective procedures, or it is at least in my health system. So I don't want to spend a great deal of time on the different types of surgeries, so how they're performed or why we're going to prefer one procedure over another. That's really outside the scope of the presentation, but I did want to briefly compare sleeve gastrectomy, which is on the left, Roux, which is in the center, and single anastomosis duodenal ileal bypass with sleeve gastrectomy, or SADIS, which is on the right. And I really wanted us to see how each of these procedures can impact medication use down the line. So that's why I wanted to go through these very quickly. So in the center, you can see a stomach and a small intestine snip before the surgery. And then on the left, you can see in the vertical sleeve, the sleeve is made by removing a portion of the stomach and the small intestine is not bypassed. When we compare that to the other two procedures, so for the Roux, which is in the center, you can see the duodenum, which is part of the small intestine, is bypassed. And finally, for the last procedure, I really kind of dumb this down for myself and think of it roughly as combining elements of a sleeve and a bypass. So we are going to bypass that duodenum. So based on the previous slide, from a medication standpoint, we can see that there are really two main results of a procedure. It's restrictive or it's malabsorptive. And I guess the third condition would be it's a combination of both. So for procedures that result in restriction, they reduce the stomach size, limit food intake, and create a feeling of fullness. So that's really the gastric sleeve or the lap band. Then there are procedures that result in malabsorption, and those are ones that bypass a portion of the small intestine, resulting in reducing nutrient absorption. And some procedures, like our Roux are going to fall into both categories. So at SSM Health, these procedures that fall into both categories, like our Roux or our SADIS, are really preferred by our weight management department. So when we think about medication management, we're really dealing with restriction and malabsorption. And I think it's important to remember that as we start to discuss these physiological changes and the potential impact on medications, I think it's also important to realize that there's not a lot of great data out there with regards to medications and metabolic procedures, which is why the typical GDMT rules may not apply. And if I can have you take away 2 points from this section, it's the following principles. After bariatric surgery, there's a lack of clear guidance on specific medication management strategies, and we should really individualize therapy. And the second point would be that the surgery type matters. The impact on medication absorption varies by the type of bariatric surgery, and we're going to see more on that in the next slide here. So I thought this was a really great table, so I didn't even bother to update it. I stole it from a 2020 review and the Canadian Family Physician. And I liked it because it really talked about the anticipated pharmacokinetic changes after a weight loss procedure. So some points to ponder for the remainder of the hour are that there are 4 common pharmacokinetic parameters that are shared by both restrictive and malabsorptive procedures, so like our Roux, and when these are going to happen will be immediately after the surgery. And so we're going to see immediate decrease in gastric motility. We're going to see a decrease in gastric volume, an increase in gastric pH, and a decrease in the stomach surface area. There's also 3 pharmacokinetic parameters that change with malabsorptive procedures only, and they're going to happen immediately after, and in the case of SIP substrates, also in about 6 to 8 weeks. So those changes are we're going to see less contact with bile secretions. We're going to see lower exposure to carrier proteins like P glycoproteins found in the proximal small intestine, because remember, we're bypassing that duodenum. And we're going to see an increase in the first pass metabolism for our CYP3A4 substrates, also because we bypass the duodenum. But if we look at this table, we're going to see that for the CYP enzymes, that activity may actually increase with weight loss. So this is something that we want to be aware of. So remember when I said there's not a lot of guidance out there on how to apply these principles? In the absence of solid guidance from our American associations, there is a great Canadian adult obesity clinical practice guideline. And I think that's a really great place to start. There's a chapter in the guidelines that refers specifically to post-operative management, and I'll attempt to summarize that in the following slides. And I feel like that really gives us some soft rules or some, I guess, things to consider when we're managing these patients. So to start off with NSAIDs, if we have someone with a sleeve, we always want to give them a PPI. If they're going to have to take an NSAID, they need to have a PPI. And for our Roux-en-Y or SIDIS patients, we're going to avoid that. And that's really due to ulceration and perforation at that anastomotic site. So you may be thinking like, well, wait, what the heck is that? So really when we're doing this procedure, we're going to form a new connection between your intestines and your stomach, or your pouch and your intestines. And really when you make that new connection, you can have leakage during that healing process. And you can have escape of digestive juices and partially digestive food through that site. And it's a pretty severe complication following Roux-en-Y. So when we talked about the bile, back on this previous slide, when we talked about the potential decrease in, less contact with bile secretions, that's where we're going to think about our hydrophilic versus lipophilic medications and which one of those are preferred. So the short story is the hydrophilic medications are going to be preferred. And we're going to plan to discuss this a little bit more further in the cardiovascular section at the end of the talk. But as a refresher, beta blockers, so when we think about our beta blockers, I'm going to pick on the ones that we use for GDMT and heart failure. So I'm going to pick on my metoprolol succinate, which has moderate lipophilicity, my carvedilol, which has high lipophilicity, and bisoprolol, which also has moderate lipophilicity. And we're also going to consider hydrophilic versus lipophilic for our statins. So our lipophilic statins, we're going to think about atorvastatin and simvastatin versus our hydrophilic statins, which would be rosuvastatin and pravastatin. We also want to be mindful of how food can impact some medications. So the decreased volume of food and fluid can impact the medication administration. So I listed some examples of medications that we recommend taking with food, and these recommendations are based on a risk of stomach upset, their absorption, or the potential to cause side effects of taking on an empty stomach. We also want to be mindful of tablet size and the gastric pouch if possible. So one of the papers had a really delicious comparator for tablet size, and I'm assuming that these are plain M&Ms and not my own personal favorite and by far superior, the peanut butter M&M. But they said that tablets that are greater than 10 millimeters or size of a plain M&M candy may not dissolve as well in the gastric pouch. So this is just something as well to be aware of as we're talking about medications. So we also want to be mindful of the P glycoprotein substrates because we're going to see lower exposure to those carrier proteins because they are found in the proximal small intestine. The degree of the effect on P-glycoprotein substrate serum concentration can be altered by the dose and timing of an orally administered inhibitor or inducer. So we need to be mindful of this interaction. I listed some common substrates below here. So our DOACs, colchicine, and digoxin. For the same reasons, which are bypassing the small intestine and then the subsequent substrate inhibition and induction, we also want to be mindful of our CYP substrates, particularly CYP3A4. And remember, we care about these not just immediately after, but also 6 to 8 weeks out, as the CYP activity can increase with weight loss. I listed some common CYP3A4 substrates below. I'm going to pick on the statins again here. So just as a refresher, it's torvastatin and simvastatin are metabolized by your CYP3A4, whereas your rosuvastatin and pravastatin really have limited CYP3A4 metabolism. And finally, I stole another table shamelessly. This slide shows some general considerations for medication management post-op. I really like the focus on individualized therapy based on clinical response versus a blanket change in medication, especially given patients, or maybe it's just that most of my patients could have a stockpile of medications at home to use up. What I thought were two interesting discussion points to pull out of this table would be the solid to liquid dose change. So patients often ask me if they're going to need to change to liquid medications, either in the short term or long term. And I really want to talk to my patients about the cost burden for liquid formulations. If the patient's tolerating and responding to therapy, I don't put them on a liquid version. I'm going to look to see if the solid dose can be crushed or if the capsule can be open and sprinkled in pudding or applesauce. And the second thing we're going to go through is the change from XR to IR formulations. So when I graduated, the recommendation was to always change an XR or controlled release to an IR. We're going to get to that a little bit more in the diabetes section when we talk about metformin. I have some maybe controversial thoughts on the metformin particularly, but again, I really let clinical response be the guide for my patients when considering changing a medication. So now we're going to move on to potential barriers of care for patients undergoing Roux-en-Y. So this slide highlights some of the challenges that I've seen in my patients with regards to cost. I think that most of us get hyper focused on the cost of the procedure, but there's a cost associated with the post-op needs as well. For example, Badger Care doesn't cover the cost of the supplements. So this presents a really unique situation where the surgery, which is thousands of dollars, is covered, but the post-op medications aren't covered. Also, patients may not have paid time off as part of their employer benefits package. And there are also restrictions on driving and weightlifting that could impact their return to work and their ability to make money. Also, their protein needs are going to be about 60 to 80 grams a day, and they're going to aim for that at least 60 grams of protein in a day, and that can get really expensive, right? So at least half of the protein intake should come from lean protein-rich food sources, and the other half can come from supplements like protein shakes or protein powder or things like that. And some of the caution foods, which we'll get to in a bit here, are also some of the more delicious or cheaper options, like ground beef, sausage, bacon, fried or fast foods. We also want to think about the cost of excess skin removal post-op. So that's an additional financial cost that is typically not covered by insurance, and we need to think about how we're going to talk to patients about that as well. We also want to talk about the stress and emotional impact of the surgery. So this slide highlights some of the challenges that I've seen in my patients. First up, there's so much misinformation or incorrect information out there, like I can't drink through a straw. It can be really overwhelming to know what your life is going to look like post-op. So you could be discouraged if you're not losing weight as fast as expected. You could feel judged by your family or your coworkers for taking the easy way out. You can't see me air quotes that. Also, it can be challenging to juggle meals for a family and a patient if there's different diet needs. There's the consideration of, is this going to change the relationship to food? So is it going to make it better? Is it going to make a sustainable plan for healthy eating? Is it going to make it worse? Are you going to become hyper focused on counting macros versus the quality of your food? And then what patients most often tell me is they want this to cure their comorbid chronic diseases. Um, so I think there's a lot of feelings on this slide, and um, you need a good support system post-op. Otherwise, your recovery time could be slowed. You could maybe not respond as well because you don't have that good support system to handle all of the feelings that are on this slide, plus more. So I think in summary, when we're following up with our patients, it's important to check in not only on the medications, but also on their mental health and well-being. So I also wanted to go over some common side effects of the procedure, as these symptoms can be confounding factors when we're trying to adjust medication therapy for comorbid chronic diseases. We can reinforce the lifestyle changes to mitigate when appropriate. And pharmacists and pharmacy technicians can also play a role in ensuring that the patient has access and is adherent to the supplement regimen. So, first up is nausea. So sometimes it's really hard to tease out, is this caused by a dietary indiscretion? Is it a side effect of the procedure, or is it a side effect of a medication? So when I'm thinking about what medications can increase the risk of nausea, and I'm specifically thinking about my diabetes medications, I'm picking on things like GLP-1s and metformin. Next up is dumping syndrome. So, what the heck is dumping syndrome? So, it's a condition in which food, especially food that's high in sugar, moves from your stomach or your pouch into your small bowel too quickly after you eat. And this can really happen anywhere between 1 to 3 hours after a meal. And about 15% to 20% of patients can experience this after a weight management procedure or a bypass procedure. So, to minimize the risk, if we do have a patient on a liquid medication, we want to make sure that we choose a liquid dosage form that's low in sugar, and we want to avoid those with non-absorbable sugars. So, luckily, the fix or the mitigating change is the same for nausea and it's the same for nausea and dumping syndrome, and that's lifestyle. So we tell people we want them to eat smaller meals and eat more often. You can have snacks throughout the day if you need to. You want to eat slowly and chew your food carefully. And you also want to change what you eat. So you want to avoid the foods that make the symptoms worse. You're going to say eat more vegetables, lean proteins, foods that are high in fiber and complex carbs. You want to eat foods with soluble fiber. You want to have foods that have protein and healthy fats, like salmon. And you want to choose low fat dairy. You want to avoid foods that are high in simple sugars, like our sugary drinks and candies and cookies and cakes and all of the delicious things. Um, you want to avoid canned fruits that have sugar or syrup. And you want to avoid juice that has high fructose corn syrup or is concentrated. And you want to really try to avoid fried foods or things like hot dogs or other highly processed meats. So that can all help with the nausea and also with dumping syndrome. So another complication is nephrolithiasis. So that can occur when unabsorbed fat in the intestine binds with the calcium, which would typically be binding up the oxalate. So then what happens is you get the oxalate reabsorbed from your intestine, filtered by your kidney, and you end up with calcium oxalate stone formation. The risk is intermediate for Roux-en-Y procedures, and it's another reason we don't want them to stop the calcium citrate supplement. Bone loss can be another side effect of the procedure. So a major cause of bone loss is impaired intestinal calcium absorption, which can impact your parathyroid hormone and bone resorption. There's limited evidence for monitoring, prevention, and treatment in this setting. But like any patient at a risk of osteoporosis, we should encourage routine physical activity in addition to the supplementation of calcium citrate and vitamin D. And calcium citrate is preferred over calcium carbonate as it's better absorbed in the absence of gastric acid. And remember that our gastric pH is going to be increased post-op. So when we talk about managing the side effects of the procedure, we also want to discuss alcohol intake. We live in Wisconsin. So this should be minimal or avoided, especially in the immediate um, post-op phase, because it can change pharmacokinetics. So, for example, in women who are post-Roux-en-Y, it has been hypothesized that 2 alcoholic beverages could be equivalent in absorption to 4 alcoholic beverages. So you really want to watch your tolerance level in quotes with your alcohol intake. And you also want to talk about weight regain as a result of these after these procedures. So your lowest weight point typically occurs 1 to 2 years post bariatric surgery, and weight loss stops partially because of the adaptive changes in the intestine. It could be a change in patient habits, and they suspect it could be some metabolic adaptation. So after that 1 to 2 years, it's normal to expect some weight regain, but there's not really any consistent or absolute number in the literature that defines pathological weight regain post bariatric surgery. So one study reported that mean weight gain at 10 years post-op of 12% of total body weight, which actually translated into regaining 34% of the maximum weight lost in 1 year. And from the Canadian bariatric surgical sites, we're seeing that they're expecting maybe a 25% regain of total weight loss over time. So, what can we as pharmacists do to help? Well, we can try to avoid the medications typically associated with weight gain. We can, like our sulfonylureas, and we can try to make sure that conditions that can contribute to weight gain are treated, like our hypothyroidism. So I hope that in the previous slides, I didn't convince everyone that surgical interventions for obesity management are horrible, because they really aren't. For some patients, this is needed to mitigate the risk of progressing comorbid chronic conditions. I just want us, meaning pharmacists, technicians, and students, to be mindful of risk so that we can help our patients because they deserve it. So now we're going to move on to identifying key considerations and recommendations for management of diabetes in the perioperative state. We're going to start with some information on nutrition, and then we're going to move on to the medications. So in order to discuss diabetes management, we need to first touch on the pre and post-op diet requirements. I didn't realize what this entailed until I started managing this patient population. And so I wanted to give a big shout out to our nutrition collaborators at SSM that were willing to share their expertise in this area. So patients about 2 weeks pre-op are going to start a liver reduction diet, and it's a what I call an uber low carb diet. It's going to be less than 50 grams of total carbohydrate in a day. So by following this low carbohydrate or liver reduction diet, your body is going to be forced to use up the stored carbohydrate or glycogen in your liver. And glycogen and a quantity of water are going to leave the liver, and therefore it will shrink and become softer and more flexible and easier to manipulate during the surgery. So if we look at what the diet looks like, it's going to look strikingly similar to the foods that we recommend in again, you can't see the air quotes, ideal world for diabetes management. And I say that tongue in cheek because I don't know that I've yet to meet a perfect diabetic. So we want to consider the impact this could have on a patient that takes a medication with a high risk of hypoglycemia, such as mealtime insulin or a sulfonylurea. And in the following slides, when I talk about the pre-op holding of medications, I'm referring to the 2 weeks prior to the procedure or when the patient starts this liver reduction diet. Then as we move to the post-op period, really how quickly someone advances through the phases depends on the patient's tolerability and comfort level. So hence the broad time range there. It's been what I've seen that patients typically move from the liquid diet to soft foods as soon as possible. And honestly, I can see why. So during the immediate post-op period, getting in the recommended 64 ounces of fluids and 60 to 80 grams of protein per day is a challenge. They just aren't hungry or thirsty. So thinking ahead, can you guess what medications to treat diabetes or cardiovascular comorbidities that we would worry about with limited hydration? And spoiler alert, it's SGLT2s and diuretics. Again, the meal plans recommended by the dietitians contain foods that have high quality proteins, i.e., ones that are low in fat. They have low or to no added sugar and lots of non starchy veggies. And again, those protein supplements can be used, but they don't want more than 50% of the protein coming from this source. So, moving on to medication management, I'd like you to keep these points in mind as we discuss the management of diabetes in the perioperative state. We want to think that procedures can result in both restriction and malabsorption. We want to think about the side effects of the procedure, particularly nausea, vomiting, and dumping syndrome. And we want to realize that patients can start seeing improved glucose control even as soon as 2 weeks pre-op when they start that liver reduction diet. So some points to ponder as we move through the next few slides would be, can we consider the impact of those pre-op diet changes on a patient that takes a medication with a high risk of hypoglycemia? And can we consider the impact of the procedure on which is increased satiety or challenges getting in fluids and nutrition? So what impact could that have on a patient that takes a medication with a high risk of hypoglycemia or a medication that has a high risk of dehydration or something like a GLP-1 agonist? So I snipped this directly from LexiComp and specifically from the glipizide drug information, just so you have an FYI on the source. I wanted to give us an idea of the timeline of insulin secretion and insulin resistance or sensitivity improvement in the post-op state. It helps us communicate what patients can expect in terms of diabetes control post-op, and I think it's important to be realistic when setting expectations. So for insulin secretion and sensitivity, they can be partially or completely restored after these procedures. And then for the first phase insulin secretion and hepatic insulin sensitivity, this has been shown to be significantly improved in the immediate days after gastric bypass. And the restorative effects of these procedures on peripheral insulin sensitivity can occur later in the 3 to 12-month post-surgery. So our challenge is really going to be management at the start of that liver reduction diet and immediately post-op or in the TCM phase because the risk of hypoglycemia is high. And then as we look farther out, as our insulin sensitivity increases due to weight loss, we're probably going to have to make some medication changes as well. So, having said that, what we see in practice is that if a patient has long-standing diabetes, particularly with a fairly high insulin need, it's unlikely that the patient's going to see complete remission of diabetes. It's to the point that they don't need to be on any medications to manage diabetes. So, it's really important to have that discussion with your patient. You may need to be on a medication, you may not need to be on a medication post-op. We just don't know until we get there. The hope is not. We will keep our fingers crossed. So having an estimate of when and to what magnitude the insulin need and sensitivity changes from the previous slide, there's three concerns we really want to consider when we're managing medications for patients in the perioperative setting for diabetes. So what's the side effect profile of the drug, i.e. does it cause nausea? Does it delay your gastric emptying? Does it cause dehydration? What is the risk of hypoglycemia and what is the risk of weight gain? So you're going to hear me harp on these three things continually through this portion of the talk. So as we walk through this in the coming slides, we want to keep all of that in the back of our brain. So the first takeaway from this slide is that metformin is the preferred single agent. And if we think back to those three big concerns, it's got a low risk of hypoglycemia, essentially no risk of weight gain, and it helps with insulin resistance. And it also has a very low cost. So it really remains the preferred agent if someone just needs one agent. And as we look at the section on A1C, I will say there's a caveat regarding the A1C and the weight management department in my health system. They require an A1C of less than 8% prior to the procedure. So technically, all patients fall into the less than 9% category for our team in this 2-week perioperative phase. But they're rarely on just one medication for their diabetes. So we're managing very complex patients. So our team uses this table for guidance, but ultimately the clinical decisions that we make are based on patient-specific needs and may not align 100% with this table. And finally, if a patient needs a second agent or a third agent, we want to choose one that facilitates cardiovascular risk reduction if cost permits. So in the next few slides, we'll plan to address agents commonly used to manage type 2 diabetes, beginning with metformin. So I wanted to first address the side effect profile of metformin XR versus IR. As we commonly see in practice, intolerance to these reactions that are listed, like diarrhea and nausea and vomiting, are a reason for discontinuation of therapy. And you can see there's a pretty stark contrast between IR versus XR and the side effects. So for pros, we talked previously, there's a low risk of hypoglycemia and weight gain. Some cons would be it's a large tablet size. There is an increased risk of side effects, particularly with the IR formulation. Pre-op, we're okay to continue this medication, but we do want to hold it the evening prior to and morning of the procedure if it's been continued during that liver reduction diet. Post-op, if the patient is only on one oral diabetic medication, like if they're only on metformin, we're okay to hold it post-op. If they're on more than one oral medication, so metformin plus something else, and their A1C is less than 8%, metformin is going to be preferred. We can always dose reduce it as we need it to. And I also want to discuss the change of XR to IR, specifically for metformin. When we consider the pathophysiology of type 2 diabetes, we have precious few medications that target one of the core concerns, which is insulin resistance. And metformin is one of them. It's affordable, and if it's tolerated, there's some evidence to show that it has cardiovascular benefit. It may, and I'm going to say may here, because the evidence is, I would not say it is robust for these, but it may slow cognitive decline, may lower the risk of cancer, and it may increase the life expectancy in patients with type 2 diabetes. So we know that metformin is primarily absorbed in the duodenum, which is the area that we're bypassing for Roux-en-Y. But when searching the literature, I couldn't really find much solid data regarding the absorption of immediate release versus extended release oral formulations. And when we're really considering this conundrum, it's important to note that metformin is not a medication that has a narrow therapeutic window. I also wanted to discuss what happens if we happen to crush metformin XR. So to do that, I had to go back to the package insert for glucophage XR. And the answer is it may decrease absorption, but it doesn't make it become toxic. So in case you can't tell, I've been preparing you for an unpopular opinion, which is I would continue the XR given the side effect profile of the IR formulation. Based on response, we can change to the IR if needed. And that recommendation is based on the therapeutic window, the side effect profile of the IR, the ability to crush XR tablets in a pinch. I really just don't want to set my patients up to fail with the IR unless it is necessary. So as we take a deep breath, this slide is going to be much less controversial than the previous one. I did lump sulfonylureas and pioglitazone on the same slide, given that they have similar side effect concerns. And the pros and cons for the purpose of this presentation only are very similar. So I'm not implying they have the same mechanism of action. They're two different drugs. I'm just putting them together for brevity's sake here. So potential side effects will be hypoglycemia and weight gain. The pros would be it's a low cost, they're cheap, they have a small tablet size. The cons would be the side effects that we had referenced above. So the short story is I would really recommend holding these or avoiding these if possible in the perioperative phase. That's really due to the side effect potential, that hypoglycemia and weight gain risk. Um, if we do continue them at if we do continue with sulfonylurea or pioglitazone, we want to make sure that it's held the morning of the procedure. So full disclosure, I don't see acarbose used very often in primary care where I practice, but I wanted to include this in case you start managing a patient that comes to you on this medication. And I really suspect that the dwindling use in practice is likely due to the side effect profile and administration regimen. So the side effect profile per lexicomp is flatulence, diarrhea, and abdominal pain, and you can see that this is not rare, and it needs to be administered with the first bite of each main meal. Um, so the short story is the concern is that these symptoms are going to overlap with the side effects of the procedure. So pros would be low cost, small tablet size. Cons, what I just mentioned, the risk of the overlapping um, symptoms that are the side effect of the procedure. So we can continue that in the pre-op phase if we need to. I would really avoid resuming that acutely at least. We can reevaluate the need for therapy down the road. If we have to continue it, if we choose to continue it pre-op, we would hold it the morning of the procedure if it's been continued during that liver reduction diet. So I'm also seeing fewer and fewer prescribers initiate DPP-4s in the era of SGLT2s and GLP-1s in primary care. But again, I wanted to include it just so that you would have exposure to it. So potential side effects would be arthralgia. And then there are reports for saxagliptin, an increased risk of hospitalization due to heart failure. Pros would be a low risk of weight gain, a low risk of GI side effects and hypoglycemia, and it's a small tablet size. The con would be that it's high cost. It's okay to continue pre-op, and it's actually okay to continue post-op as well. There's limited safety data, but it's low risk. For my patients, I really want to look at the cost versus benefit of this medication. If we do continue it pre-op, we want to make sure that we hold it the morning of the procedure. So at the PSW educational conference earlier this year, Karen Kopachik and her team gave a really great presentation on the management of patients with heart failure that included some great information on SGLT2s. So I would refer patients back to that talk for information on SGLT2s, but I'm really going to try to focus on the use perioperatively for diabetes in this section. So side effects would be acute kidney injury, hypovolemia, euglycemic DKA, and then the fungal infections. Pros would be a low risk of weight gain, small tablet size, and the benefit to cardiovascular health and chronic kidney disease. And the con really is the risk of dehydration, particularly post-op, because they're just not going to be drinking as much. They're going to have to really fight that. And I've heard of people have to set reminders on their phone to make sure that they're getting enough fluid in. So that's really for the SGLT2 inhibitors a big concern. So pre-op, we're going to hold that 3 days prior to the procedure. And there's a caveat alert. So for empagliflozin, dapagliflozin, and sotagliflozin, if they happen to be on sotagliflozin, we're going to hold that for 3 days. But the new bexigliflozin, we're going to be able to discontinue that 3 to 5 days prior to surgery. So that's a newer agent for type 2 diabetes. It's available on the Cost Plus Pharmacy website for about $50 a month. So we have been using that in our team for diabetes management in a pinch if someone has cost challenges. And when we think about resuming this post-op, In the diabetes setting, we're going to hold it for at least 6 weeks. And then we're going to consider the risk versus benefit of resuming. And now we're moving on to GLP-1s and our GLP-1 GIP agonist, so Mounjaro. I think that, this class of medications, it's been really amazing to watch someone that struggled for so long see some positive progress. It really is a miracle drug for some of my patients. Um, they they just feel like they're stuck, and then they start one of these agents and they feel unstuck. Um, so some things that we would see post-op would be in alterations in the secretion of glucagon-like uh, peptide 1 or GLP-1s from the gut following bariatric surgery. And that's a key mechanism behind the successful initial weight loss. So, research and meta analyses indicate that postprandial GLP-1 levels rise after Roux-en-Y, but that fasting GLP-1 levels don't show a significant increase post-surgery. We know that ghrelin or the gremlin hormone levels decrease after the metabolic surgery. And as we start to think through the risks versus benefits of these classes of medications in the perioperative setting, we really want to start with side effects. And a major concern that we have is that these symptoms may overlap with the potential side effects of the procedures. So, constipation, diarrhea, nausea, vomiting. The incidence of these is fairly common, or sorry, fairly consistent amongst once weekly formulations, but we're particularly concerned with the vomiting. And another risk of Roux-en-Y, and the reason we're concerned with the vomiting, is that anastomotic leakage, or that escape of digestive juices and partially digested food. That's a complication of Roux-en-Y. We don't want someone vomiting because of their GLP-1 and making it worse. So a pro would be a low risk of hypoglycemia. We're seeing emerging data that use post-op can be beneficial for weight management, and also has cardiovascular and chronic kidney disease benefit. Apologies there. Cons would be high cost and higher risk of GI side effects. So really, as we start to think about what we want to do pre-op, we're going to get to kind of the elephant in the room here. I guess before that, as we talk about the perioperative management, I will say that when managing this class of medications, we see some variation between clinicians and health systems. Um, the It's really practicing the art of medicine in the setting of evidence-based GDMT. For example, when we had our August 1st PSW Network Ambulatory Care Member Meetup, did you like how I shamelessly plug that there? There was a great discussion on transitioning between GLP-1 agents. I came away from that discussion feeling that we all have the same goal. We want to do what's best for the patient, but how we get there is nuanced. So now we're going to get to the elephant in the room, and that's holding pre-op for these agents. So caveat alert, how could we forget when the American Society of Anesthesiologists reported an increased aspiration risk for patients on a GLP-1? That was a kerfuffle. So I'll throw in that if your health system has a different policy for holding GLP-1s, stick with that. I put okay to continue. In my health system, we weigh the risk versus the benefit when considering a whole pre-op. If a patient is tolerating it, i.e. there's no reports of nausea or vomiting, we're okay to continue it. If the patient is struggling with regards to tolerance, we want to maybe consider holding. If it's continued, you could consider a longer fasting period or liquid diet pre-op, but there's no evidence to support that that's going to help. And so really, I call that a feel-good step or change. I will say that for most of my diabetes patients that are having a Roux-en-Y, prior to surgery, you're going to have to pry that GLP-1 out of their hands. Because it's been such a game changer for them for blood glucose and weight management, you probably have better luck taking candy away from a toddler at that point. Post-op is a little bit of a different story, but pre-op, it's hard to get them to stop pre-op. Um, So after all of that, we're going to move on to what do we do in the post-op setting. So again, we all have different approaches here, and that's even amongst our team and my health system. So some have resumed the GLP-1 at the same dose pre-op, others reduce the dose, others initially hold it until the GI symptoms from the surgery are more stable. Personally, I'm inclined to leave it on board if the patient is tolerating, at least in the short term, especially if the patient struggled with glucose management pre-op. So for example, they were on 4 oral agents and or they were on high doses of insulin. If the patient was well controlled on 2 oral agents plus a GLP-1, say maybe they were on metformin and an SGLT2 and a GLP-1 pre-op, I'd probably do a dose reduction. It's truly patient-centered care, and the key benefit to having a pharmacist provide this periop management is that we're going to discuss the risk versus the benefit with the patient. And we're going to make a plan that's going to be sure to consider not only the safety, but their long term goals. So, this table provides some useful guidance for insulin management in the post op state, but what about pre op? Well, once patients start that liver reduction diet, you can see some pretty drastic changes in blood glucose depending on the pre-diet intake. But if we don't have a crystal ball to really know the magnitude of that glucose lowering. In the world of GDMT and evidence-based medicine, the fact that this is an art is a little hard to get used to at first. Um, when making a perioperative plan for insulin management with the patient, I have a pretty frank discussion with them. I disclose there's no solid guidance on how to manage their insulin pre-op. We're going to use their self-monitor blood glucose results to guide us. And so it's really important for them to understand that they're going to have to be maybe poking their finger several times a day. The good news is that motivation is usually high in this patient population. And in current state, many patients can get access to a continuous glucose monitor. Either it's covered by insurance, we can use a free trial, or they're just willing to pay out of pocket in a short term period for a CGM. So I highly recommend using a CGM if they have access. In most cases, I feel pretty comfortable providing the patient with some self titration directions. And again, that's given their high motivation. We discuss appropriate reduction of insulin and when to call the clinic with questions. And we also make sure we have a prescription for glucagon on file. I typically recommend a 20 to 40% reduction in insulin dosing based on their self monitor blood glucose readings if they start to get lows once starting that liver reduction diet. I've had some patients be able to stop insulin pre-op, and maybe they're continuing their GLP-1 or other agents. I tend to be pretty aggressive with insulin de-escalation if possible, and usually patients aren't fighting me one little bit on that. So that was a lot, and some of it was controversial or it really had no definite answer. So how do we know where to start with diabetes management? So we know that the management of diabetes in the perioperative state is nuanced, especially for complex patients that we see in practice. It's clear that if we use agents to get them to an A1C of less than 8%, we're going to want to continue them pre-op for the most part. And we have some guidance on sulfonylureas and insulin and SGLT2s pre-op as well, based on blood sugars or risk of side effects. But what happens after? And how do you make a plan for the patient post-op with no crystal ball, so to speak? So there are some things that I consider when I'm thinking about making a plan for a patient. So the first is I'm going to identify events that can alter blood glucose. So things like starting the liver reduction diet, that immediate post-op or TCM phase, and their ongoing needs. So 1 to 3 months post-op as their diet advances. I'm also going to make sure that the patient is very aware of their self-monitored blood glucose targets. They're going to know when to de-escalate their insulin therapy, and they're going to have access to a CGM if possible. So those are all great jumping off points. I also want to make sure that I eliminate medications with the highest risk of hypoglycemia or weight gain if possible. I want to make sure they hold that SGLT2 for 3 days pre-op and 6 weeks post-op. And I want to make sure that I know that metformin and GLP-1s are friends. So now we're going to move on to management of cardiovascular comorbidities. So a recent review and meta-analysis in the International Journal of Obesity reports that there's emerging literature that suggests metabolic surgery can reverse remodeling and improve cardiac function, so left ventricular ejection fraction, in obese patients with heart failure. However, the 2024 ACC expert consensus on the treatment of heart failure with reduced ejection fraction, it doesn't mention metabolic surgery as a first or second line therapy. And given the most recent approval for GLP-1s to improve cardiovascular outcomes in patients with heart disease and obesity, it's going to be really interesting to watch this evolution. So just a few days ago, Lilly released the results of the Summit phase 3 clinical trial in which tirzepatide demonstrated statistically significant improvements in primary endpoints with a reduction in the risk of heart failure outcomes and improvements in heart failure symptoms and physical activity. So it's worth noting that perioperative management of hypertension and hyperlipidemia are frequently discussed in the setting of metabolic procedures. Both are discussed in the PSW article I've referenced earlier, the Canadian Family Physician article I referenced earlier. It's also discussed in the June 2024 updates to the bariatric surgery and medication use article and pharmacist letter. But heart failure really isn't addressed a lot in these. So we're really kind of left out on a limb there. And that's a big concern with patient safety. So I'm going to focus on heart failure in the upcoming slides and mostly do a really quick review for hypertension and lipids. So recall time again, I want to keep these points in the back of our brain as we discuss management of cardiovascular comorbidities in the perioperative state. So again, a reminder, we have both restriction and malabsorption for Roux-en-Y. Side effects of the procedure are going to be decreased fluid intake, and we're going to anticipate some pharmacokinetic changes, and remember, changes to those enzyme metabolism. So when we're thinking about these changes, again, I'm going to harp on the dehydration. So that's the SGLT2s and our diuretics. So we went over this class, the SGLT2s, pretty extensively in the diabetes section, but there are some nuances for heart failure. So side effect profile is listed. Pros would be it's GDMT for both heart failure with preserved and reduced ejection fraction. Cons would be the risk of dehydration. So the reminder again, that 3-day hold for most of your agents. And then post-op, this is really where we see that change. We're going to consider resuming that post-op, particularly if the patient has heart failure with reduced ejection fraction. And we're going to educate them on the risk of AKI and hypovolemia. So it's another kind of, you need to make sure you drink enough fluids after this procedure. And here we're going to go through all of the 4 pillars of GDMT for heart failure. So here we're thinking about beta blockers that are used for heart failure with reduced ejection fraction. So our metoprolol, succinate, carvedilol, and bisoprolol. So for heart failure with reduced ejection fraction, that's less than 40%. And for reference, a normal left ventricle ejects about 55 to 60% of the blood in it. So potential side effects will be hypotension, bradycardia, dizziness. Pros are that it's GDMT for heart failure with reduced ejection fraction. Cons would be the risk of side effects. So pre-op, we're okay to continue these, including the morning of procedure. And post-op, we're going to continue acutely, but we're going to monitor that blood pressure, particularly with carvedilol, because we may need to adjust that dose with weight loss. And I wanted to talk about the MRAs and loop diuretics on the same slide, given that they have similar side effect concerns and pros and cons for the purpose of the presentation. Again, I'm not saying these have the same mechanism of action. I'm just lumping them together for brevity's sake. So in this slide, we're going to think about the MRAs that are used for heart failure with reduced ejection fraction, or spironolactone and eplerenone. And for heart failure with preserved ejection fraction, the 2023 ACC expert consensus recommended that we consider spironolactone for women with all ejection fraction and men with a left ventricular ejection fraction of 55 to 60%. For our loop diuretics, or furosemide is what I see most commonly. Ideally with GDMT and the surgery, we're going to be able to get these to PRN use. So potential side effects AKI, hypovolemia, and hypotension. Pros are that they're in guideline-directed medical therapy for heart failure with reduced ejection fraction. Cons would be the risk of dehydration. So we're going to continue that pre-op where the MRAs and the loop diuretics if needed. But we're going to hold that the morning of the procedure. And then post-op, we're going to consider a 50% dose reduction in the acute phase. And I think it's worth mentioning that fluid status is probably going to be the most challenging to manage in the TCM phase for us. So for this reason, our team follows up pretty frequently during the first couple of weeks, and we want to make sure we're continually assessing fluid status and we can make adjustment to those diuretics if needed. So if we reduce the diuretic in the immediate post-op period, we'll be talking with the patients multiple times, and we can increase that during the first couple of weeks post-op if we need to. Here we're considering ACEs and ARBs and ARNIs for people with heart failure with reduced ejection fraction. So we're looking at hypotension for side effects, hypotension, bradycardia, dizziness, elevated potassium. Again, pros would be that it is guideline-directed medical therapy. Cons would be risk of side effects. We're going to continue these pre-op, but we're going to hold them the morning of the procedure. And post-op, we're going to continue that acutely, but we're going to reevaluate down the road because we may need a dose reduction with weight loss. So how do I know where to start with these agents? So we're going to focus on the risk of benefit of the GDMT and the prior left ventricular ejection fraction. So do they have heart failure with reduced or heart failure with preserved? We're going to also stress adequate hydration for these patients, as the highest risk comes from the diuretic use immediately post-op. And we're going to have them continually monitor their blood pressure with weight loss so that we can safely adjust these medications. And this is really an opportunity for pharmacists to get involved with the blood pressure management, so we can show them how to use a blood pressure cuff. We can help them select a cuff. We can validate that for them. So this is another great opportunity for pharmacists to get involved as well. If we need to, we can also refer the patient to cardiology for some more direction on GDMT. Most of these patients we're co-managing with a heart failure clinic. So we collaborate a lot with them, particularly with the diuretic management post-op. So moving on to hypertension, this is a shameless slide steal. We're going to see that this is nuanced for hypertension versus AFib versus coronary artery disease. We discussed really day of procedure holds for agents listed here in the previous slides, except for the calcium channel blockers, and those are okay to continue day of. When considering deprescribing, we're going to consider the risk versus benefit of ACEs and ARBs if the patient's diabetic. So that's going to be the last the last agent that I peel off. The takeaway is that blood pressure drops in relation to procedure, but it's possible that they may need some form of hypertension medication management even with weight loss. So we want to educate the patient on blood pressure goals and that they need to be taking their blood pressure at home. So for hypolipidemia, this is another shameless slide steal. For primary prevention, we want to consider continuing the statin in the acute phase, and then we can reevaluate the need for therapy. If the patient is on more than just statin therapy for primary prevention, we could consider keeping the statin or having that being the last medication that we peel off. For secondary prevention or for ongoing diabetes after the procedure, we're going to continue the agents, particularly the statin. We will not take that away. And it really brings up for me an interesting question of whether to continue a statin in patients post-metabolic surgery if we consider their diabetes, hypertension, and hyperlipidemia as in remission. So for me, that means an A1C of less than 6.4% with no anti-diabetic agents, a blood pressure less than 130/80 with no antihypertensive agents, and an LDL of less than 70 with no lipid-lowering agents. In this case, if no other risk factors are present, I'm wondering, will the statin slightly increase blood glucose levels, i.e., we're going to flip the benefit versus risk discussion to favor not having a statin? Um, and honestly, I don't know that I have a great answer for that. I hate to leave you with a cliffhanger, but I think it's a very specific situation where we need to discuss that risk versus benefit with the patient. And it could be that we try stopping the statin and then checking lipids again in 3 to 6 months, and then annually thereafter to reassess the need. So, how do I know where to start? Where I feel like heart failure is much trickier because of that fluid status and needing to manage those diuretics versus maybe hypertension and hyperlipidemia. I feel like those are pretty straightforward. Compare it relatively. Um, so we want to identify events that can increase the risk of AKI or alter blood pressure, and that's that immediate post-op period, and then on needs with ongoing weight loss. And we really want to make sure that the patient is aware of their blood pressure targets and they know when to de-escalate therapy and when to contact the clinic. So congratulations, you made it through the talk. So now it is learning assessment time. So our first question is, a patient is 1 week post Roux. Some physiological changes that we can expect to have already occurred are, and I said select all that apply, a decrease in gastric pH, increased CYP3A4 activity, increased satiety or an increase in GLP-1, and a decrease in gastric volume. So I selected C and D. So if we look back to slide 7, A is not correct because gastric pH becomes more basic, i.e. it increases after the procedure. B is tricky. I said it's incorrect in the 1 week post-op phase because initially we see decrease in the CYP3A4 activity because we're bypassing the small intestine that has a high concentration of the enzyme. But we could see hepatic CYP enzyme activity increase with weight loss. I selected C as correct. So that's from spoken content in slide 28, I believe. Research and meta-analyses indicate that postprandial GLP-1 levels rise after Roux-en-Y, whereas fasting GLP-1 levels do not show a significant increase. Additionally, we know that ghrelin levels decrease after metabolic surgery. And I said D was correct, the decreasing the amount of fluids available in the stomach to act as solvents. So from the list below, select potential barriers to care for patients undergoing Roux-en-Y procedures. So feeling judged by my family or coworkers for taking the easy way out, cost of recommended perioperative supplements, taking time off work for procedure recovery, or all of the above. And I said all of the above. So all of these were mentioned as potential barriers to care. So for many patients, there is both a financial and emotional cost for these procedures. So again, I said there were so many fields. For a case study for our learning assessment, we're going to use this to answer the next 2 questions. So we have a 47-year-old patient with a 5-year history of type 2 diabetes and hyperlipidemia. They come to clinic to establish care 2 weeks prior to their scheduled bypass procedure, and they're prescribed rosuvastatin 10 milligrams daily, metformin extended release 2,000 milligrams daily, dapagliflozin 10 milligrams daily, semaglutide 2 milligrams weekly, um, insulin glargine 80 units daily, and insulin aspart 20 units with meals, plus a 1 to 20 sliding scale. They check their sugars 3 times daily, and their most recent A1C 2 weeks ago was 7.2%. All other labs are within normal limits. So what changes would you make at the 2 weeks pre-op visit? And we're going to select all of these that apply. So provide guidance that both insulin doses may need to be reduced 20 to 40% once the patient starts the low carbohydrate liver reduction diet. We're going to stop semaglutide or Ozempic, Would you stop dapagliflozin 3 days prior to the procedure? And would you change metformin XR to IR? So this one may ruffle some feathers, and I don't know that there's a 100% correct answer outside of C, which would be stopping the dapagliflozin 3 days prior to your procedure. So for this was spoken in, I believe, slide 29. Um, so I said that A was correct because once they start the liver reduction diet, I've seen greater than 40% reductions needed for some of my patients. Our job is really to educate and empower our highly motivated patients to continue to make educated choices regarding their health. I said B was incorrect for two reasons. Number one, there's a low risk of hypoglycemia. And number two, there's some weight loss appetite control benefit to this class of medications. And that's from slide 28. And I said D was incorrect because I would decide whether I needed metformin, XR versus IR based on clinical response. And that's from slide 23. Um, and what we didn't talk about in the post-assessment was adding a CGM. So I would do this, or I guess wasn't in the slide here, but I would do this as it would be beneficial for the patient in the 2 weeks pre-op and maybe 1 to 2 months post-op to help make or solidify some of these choices here. So what changes would you make at the 3-day post-op visit? So would you further reduce both insulin doses by 50 to 80%? Would you reduce semaglutide doses by 50%? Would you resume the dapagliflozin, or would you stop the metformin? And we can select all of these that apply. So I chose A for this. Patients that have a high insulin demand and a long-standing history of diabetes may not be able to completely stop insulin after the surgery. I would not immediately reduce Ozempic post-op in this patient. I prefer to see if we can get them off of insulin, especially if the patient has been tolerating the GLP-1 prior to surgery. If this patient wasn't on insulin or if the patient prefers to stop due to side effects, it's not wrong, certainly not wrong to stop. I said C was incorrect. We want to hold the SGLT2 6 weeks post-op due to that risk of dehydration. And I said D was incorrect from slide 23. Again, this is the last agent that we want to take away for diabetes. And another learning assessment question. Use the following case study for the next two questions. A 62-year-old patient with a 20-year history of type 2 diabetes, hypertension, and hyperlipidemia reports to the clinic to establish care 2 weeks prior to their scheduled bypass. The patient also has a 5-year history of heart failure with reduced ejection fraction. Their last echo was 3 months ago, and it showed a left ventricular ejection fraction of 30 to 35%. They're prescribed metformin, Farxiga, Ozempic, spironolactone, and Entresto, carvedilol, furosemide, amlodipine, and simvastatin, all scheduled. They check their sugars 3 times a week, and their most recent A1C 2 weeks ago was 6.2%. All other labs are within normal limits. So what changes would you make 2 weeks pre-op? And we're going to select all that apply. Would you reduce the Ozempic by 50%? Would you stop the metformin? Would you stop the dapagliflozin 3 days prior to the procedure? Would you reduce the furosemide and spironolactone by 50% upon hospital discharge? Or would you do nothing? Or would you do none of these? And I didn't select A as correct because the patient is tolerating and there's a low risk of hypoglycemia and there's some weight loss, appetite control benefit with this class of medications. I didn't select B as correct. This is the last agent I want to pull away for diabetes management. And boy, I'm really drilling in the C or the hold SGLT2s. I'm really kind of driving that point home 3 days prior to the procedure. And I said answer D was correct. So yes, there is a risk of dehydration. But this patient has heart failure with reduced ejection fraction, and their ejection fraction is less than 40%. So I said reduce those versus stop those upon hospital discharge. So, what changes would you make at the 3-day post-op visit? Would you stop semaglutide? Would you change carvedilol to metoprolol? Would you change simvastatin to rosuvastatin? And would you resume the dapagliflozin? So I kind of went whole hog for the last question. So in theory, all could be correct. Um, so response A is reasonable if the patient's willing to and has a desire to stop the GLP-1. It's A-okay to do so, especially if their blood glucose is to goal. Response B is reasonable. Carvedilol is lipophilic, and food can also impact the absorption. So but then to play devil's advocate, we have a concern about that absorption of the extended release. So we want to make sure that that's getting absorbed given the GDMT is for heart failure. Response C is reasonable. Simvastatin is lipophilic and metabolized by CYP3A4. And rosuvastatin is hydrophilic and has limited CYP metabolism. And I would say D is correct. This is a patient with heart failure. The caveat being that we would want to educate the patient on AKI and hypovolemia risk, and we want to tell them to hydrate. So I really wanted this patient case to again highlight the nuances of patient care and why pharmacists are best suited to be involved in the care perioperatively, given the complexity of physiologic changes post-Roux-en-Y that can impact absorption and metabolism of medications. So I listed my references. And thanks again so much for listening to the talk. If you have questions or concerns, please feel free to shoot me an email at jennifer.slaughter@ssmhealth.com.